Okay, I'd like to welcome everybody to the fifth in our series of Stanford facial plastic surgery webinars. I'm very pleased to host this one, which is going to be on complications in rhinoplasty. This is a very important topic. And even though we've had so many webinars broadcast in the past few months during the COVID epidemic, I really haven't seen any that concentrated on this topic. And so I'd like to thank right up front our speakers. Dr. Brian Wong, Dr. Bahman Guyuron, Dr. Tom Wong, Dr. Paul Nassif, and Dr. Yong-Ju Jang. This is an international panel of experts who are taking the time to share and hopefully teach us something. I think learning from complications is one of the most important things you can do at any level in any surgical procedure. And it's important to be able to share this type of information. And so I want to thank our panelists for taking time out today on a Saturday to do this. So next week, just putting a plug in real quick, we're going to be talking about functional rhinoplasty and advanced septal surgery. We have a bigger panel, and I welcome everybody to register for that. Once again, it's a free webinar. So next Saturday, the same time. And this is my contact information. And I'm going to just talk about one case, one complication real quick, and then turn it over to our panelists in the interest of time. And that case is this one, which I have shown previously in a revision rhinoplasty talk. But I think it's instructive because it's a complicated situation. This is a patient who'd had multiple prior rhinoplasties. And as you can see, he's missing the skin of the tip of his nose. And how did this happen? Well, during the course of his reconstructions that he's had after a trauma, he had rib graft placed with K-wires, which was, I think, pretty common practice and still is for some surgeons. And I think that, most of the time there really aren't any issues with infection. But unfortunately, in this case, the K-wire, which is a foreign body, of course, in the tip of the nose became infected. The exact circumstances around that are unclear, but as a consequence of this, he did lose the skin of the tip of his nose. And, there's really no way to reconstruct that from a rhinoplasty perspective, from my perspective, without putting new skin in that area. I think that it was just scar tissue, and I explained to him that if we needed to do this, we need to actually reconstruct it with a forehead flap. So in this case, the first step was just debriding and taking out all the foreign body material that was in there, and then letting it cool off for several months, and then going ahead and doing a forehead flap. And when you want to do something like this, especially in a cosmetic patient, but in any patient, a skin cancer patient, trauma patient, you have to make sure that you adhere to the principles of aesthetic subunits, which were in the nose really espoused by Gary Burgett, who's unfortunately passed away about 3 years ago. And in this case, it's kind of treacherous when you think about it, because this is a cosmetic surgery patient, and you're designing where you think those subunits are, and then resecting a normal tissue. And you really have to have confidence that what you're going to do is going to end up better aesthetically for this patient. But, again, there's tissue loss here, so there's no way to do this by stretching it with grafts or anything like that, because that isn't normal skin in the tip. That's just not going to stretch. It's actually just fibrotic scar tissue. So here we are designing our subunits and then doing a forehead flap. And I put a couple of pieces of ear cartilage there just to allow it to have the space and contour. And this is a big leap of faith on the part of your patient to go through this procedure, and you're just kind of hoping that, of course, that this is going to be the right way. But from your experience with skin cancer and things that it will be. So he goes through 2 stages like that, which I skipped. I didn't show the secondary stage on the forehead flap. And then we move ahead with our revision rhinoplasty, which is kind of building up some more tip support and required anterior septal reconstruction and rim grafting. And so, really just replacing that tip took about 4 or 5 stages. And you can see here on his frontal view, his forehead flap site is healed pretty well. In the 3/4 view, you can just see slight shadowing along that donor site, which is, of course, an important consideration. But the tip projections restored by having new skin there. And so here we are with the 3/4 view, base view, and up close frontal view. And you can see there's a difference in skin texture, and that's expected. when you take skin from another part of the body and put it up close. And I think that, you know, the lesson of the story isn't so much this reconstruction for this talk. It's more about complications and being cognizant of those. And, you know, I wasn't around when he first started having an infection, but I think perhaps early intervention may have helped him. Perhaps beyond antibiotics, just going in and taking out the infected foreign body right off the bat. I think he was treated conservatively for a while. And so these are things to think about. You know, we do sometimes use foreign materials in the nose, and we have to be cognizant of that. And when we see patients, even if they're not our own, and they have something like this, it has to be taken very seriously and addressed very aggressively. So that's just my real brief presentation that I wanted to do. And I'm going to stop share now. There we go. And turn the panel over to our next speaker. And that is Dr. Brian Wong from UC Irvine, who's going to share with us a complication and talk about it and see what lessons we can learn. Brian?
Great, thank you. Thanks, Sam. This is really great that you have this running today. Hopefully this will work. I'm going to be talking a little bit about Keystone injuries. I want to thank a medical student for really helping round out some of the background on this as well. I don't have any relevant Keystones. Wow. This is Jack Gunner back from 06. He had an incidence of 1.2%. I think they had 117 Keystone injuries that they repaired. So that's a man with a lot of experience. There was a paper from general otolaryngologists looking at saddling related in septoplasty, and they had a 5.1% rate out of 2,100 patients. So, you know, something is going on. Maybe it's overzealous L-strut resection or unrecognized disarticulation of that from the quadrangular cartilage. This is a hard operation, rhinoplasty that we do. Revision rates are up to 10 to 15%. If you look in detail outside of the peer-reviewed literature where experts publish, a billion bad things can happen. You know, I really want to thank you, Sam, for the opportunity to talk, and hopefully there's some tips that I can learn from the other panelists in what follows. Thank you.
Thanks, Brian. You know, I think that is an extremely important topic that you talked about for a couple of reasons. I think that first I'm going to mention something about septoplasty. I think saddle nose and septoplasty is one of the most underreported things. I see a lot of that. I mean, just, you know, as revision patients, I think that actually saddling can occur even if the keystone's intact. If the L strut on the spine is resected too much and it flexes back into the nose, you can actually get flexion there and saddle nosing. So I think septoplasty is one of the most underrated in terms of danger procedures that's done out there in the community, and just so something to be really careful with. But keystone injuries are really important to talk about. I mean, I think there's a lot to get to here, and I hope some of the other panelists will jump in. You know, looking at my notes and just looking at your case, you see a crooked nose like that, you know you're going to have to shift a high dorsal septal deviation over if you want to get them straighter. And this is one of those topics in crooked nose that we talk about a lot. So I'm interested in what the panelists do. Some people actually will deliberately disarticulate it with an osteotome to shift it over. Some people will try to just use spreadographs and just, you know, sacrifice the fact that you can't perhaps move that septum over so you get less of a result. But the danger is if you're over aggressive, or even if you're doing everything right, it can just fracture funny. You can get that key injury. So I'm interested in what the other panelists have to say for how they treat crooked noses and how they like to avoid key injuries, and also if you have any comments about treatments you like to use. Paul, do you have any comments you want to start with?
Sure. Hi, everybody. Thank you, Sam, for having me. As a matter of fact, you mentioned this, but we just did a gentleman who had the same type of fractures, complete collapse. It was actually foreshortened and oblique on the left side of wall, and my new fellow and I did one last week. What I do, I haven't actually done the percutaneous, but I love that idea. Thanks for that, Brian. But I'll completely, especially when the bone is that much damaged, and it just doesn't need lateralization, I'll mobilize the bone completely. Of course, we'll use rib, and the extended spreadograph will go as far up needed all the way along besides the cartilaginous septum, and then go all the way along that bone to help lateralize it. Now, that's always the issue. Again, how do you fixate, as you saw, a great way to fixate the bone to the spreader graft. But again, even though you're putting up at the Keystone, you can put some sutures up there. But what I've actually started to do, since I've been using a lot of Tisseel, and again, Dr. Jang has been really pioneering this with his templates for these diced cartilage glue grafts. So I'll actually first take a little bit of the fibrin glue between, because you know that septum travels all the way up, use a little bit of that to help fixate, and it's kind of simple after the bone is done. But no matter what, I still never get a perfect contour, even after separating it about a good 6 millimeters. Then what I'll do to finish it, especially when you have that drop off in between the septum and the bone, then I'll take some of the diced cartilage glue graft and gently mold it like a pate inside that irregularity. Fixate it, look at it, make sure, again, taping and casting is so important. And that's now how I've been dealing with these. So I'm getting a combination of something really firm, but then an incredible camouflage.
Yeah, I mean, I think that, you know, when I use diced cartilage or when I'm doing reconstructions for saddles, it's two things. One is the structural support, and then the actual contour is really just what you described really nicely. And that's great. Yong-Ju, Tom, or Bahman, do you have any comments about avoiding key injuries and crooked noses, or how you like to treat them?
First, I don't deliberately disarticulate keystone for correction of deviated nose. I always try to keep it there. If there is accidental injury on the keystone area, I tried this kind of suture technique a few times, but I found it's very difficult, especially when the patient has very small nasal bone. So generally, the Asian patient has not that prominent nasal bone, so it's any drilling and further injure the nasal bones. So I tend to do the combination of osteotomy, including medial and lateral and percutaneous root osteotomy for the correcting the deviated bony axis. If there's any accidental injury, I just try. I make I harvest a strong cartilage, and I make I place a extended spread graft on one side, and then I secure the caudal support well, and then I don't do any specific bone drilling and fixation, and it is covered with the augmentation. Yeah, that's what I'm doing.
I use 18 gauge needle to create a hole in the bone and pass it through, and not percutaneous. Under direct vision, I pass 3/0 PDS suture to fix those elements together. But I want to go back to something that actually you mentioned a little bit earlier that is absolutely crucial. One of the most common reasons for the hump that develops postoperatively that was not there is because of the sinking of the septum as a result of aggressive septoplasty. You mentioned that, but I also want to stress the fact that you have to leave at least 15, but most of the time I'm leaving 20 millimeters of cartilage anteriorly so that it doesn't have propensity to sink in. And that is, so as you said, it is one of the most underrated, under stressed elements of postoperative failure. Or saddle nose deformity can occur, but commonly it is a hump that we know that we didn't leave behind, but it occurs 6 months or a year later as a result of sinking of the dorsum. It's crucial that we leave enough cartilage to support the dorsum.
You know, I think the 1 centimeter rule is definitely not completely correct.
Yeah, I'd agree with that.
Yeah.
I agree with that. I think it's tricky to try to leave the dorsal caudal strut exactly intact. And I agree with Bahman. The 2 centimeters, sometimes you leave 2 centimeters and the residual strut buckles just because of the pressure. And so it's much trickier than that. In fact, it's good that we're talking about this because part of my case presentation will go over how we cover a dorsal caudal, reestablishing dorsal caudal support. And it's a tricky problem for sure.
I want to stress one other thing. When you look at the septum through an open technique or closed technique or anything, you really see it more than it is. You have to measure it. Since we are not most of the time looking at it through binocular vision, we're not really judging the depth as much. So it is important to me, when you remove a rib cartilage, it's exactly the same thing. You're not seeing enough of it. So you think that actually you have enough length of cartilage, you remove it and it's a lot shorter than you thought it was. So please make sure that you measure it, that you leave 20 millimeters behind.
I think that advice is true for a number of things, huh?
Yeah.
The only thing that I'd add that's changed in my technique toward the severe deviation is that I use, and I have no relationship with the company, but I use a Sonopet device, which I borrowed from the neurosurgeons in Skullbase many years ago. And I contour the perpendicular plate, I thin it, and I can smooth it, and I can take it from however thick it is to however thin I want. And what that allows me to do in these severe deformations is it allows me to flex the perpendicular plate rather than push something over rigidly and create a stress force concentrated in one area where I would get a potential fracture. So knock on wood, I've been happy. I realize not everyone has that. I mean, you have to have a neurosurgeon somewhere in your practice that uses it in their cases, but that's been very helpful for perpendicular plate deformation and getting my perc plate in the midline rather than just taking an elevator and just whacking the perpendicular plate back toward midline.
Yeah, and I've been using the P zone. I think that helps, but I'm just gonna keep things rolling along because we have a bunch of really interesting topics. I'm gonna now turn it over to Dr. Bahman Guyuron, who's going to share with us his thoughts on complications in rhinoplasty. Bahman?
Well, so from as a product of these two complications, I thought that we need to figure out a different way of stabilizing the cartilage and reducing the warping, so that we don't have to resort these external wires or anything that is going to cause rejection, extrusion. So this is a suture that I have described, and I use it very frequently. It starts from the convex side, and as you can see, it is tied on the convex side enough to straighten this cartilage. It is 5-0 PDS, or on a thicker cartilage, I may use 4-0 PDS, just tight enough to straighten the cartilage. I use it for the columella, I use it for the spread grafts, I use it for the dorsal grafts, and we published this in 2018 in the Journal of Aesthetic Plastic Surgery, and it has been an integral part of my rhinoplasty. In fact, I use this suture now very frequently in straightening the different portions of the septum. This is just a mattress suture that tied on the convex side. So learning points, we need to get away from K-wires and use the warping suture when we need to. Think about the hyperbaric oxygen whenever we deal with a poor healing, whether it's the face, nose, extremities, or the abdomen, and it really serves the patients very, very effectively and helps us to get out of very difficult situations. Thank you. Sam, thank you again for inviting me.
Thank you very much, Bahman. I think those are really interesting cases, and I think a few things that, few discussion points that we can have. First is, I just want to ask about that technique. I've seen you talk about that before, and I'm going to look up the reference now that's published, but do you use that suture on any piece of cartilage even prior to its warping? I mean, so if you just have you put it prophylactically?
Yeah, what I do is, especially rib cartilage, as we know, it has a significant tendency on younger patients to warp. And the younger the patient, the more likelihood that the cartilage is going to warp. Even the fresh preserved cartilage warps. So what I do is put the cartilage in a saline for about 10 minutes. Immediately, soon, actually, within that 10 minutes, you're going to know which way it is going to curl, warp. So what I do is, again, start from the convex side and pass it back and forth and tie it. And you saw that video, how it really nicely straightens the cartilage.
Yeah, that's a really nice idea. The use of hyperbaric oxygen, that's something that we do in head and neck reconstruction sometimes for, radiated patients and things like that. I haven't really had the experience yet using it in a rhinoplasty patient. When do you make the decision to do that? And did you ever understand or find out what predisposition to infection or poor healing that patient may have had?
Again, the two back-to-back complications, poor healing on the same patient. I actually have had about a half a dozen of these patients that had undergone multiple surgeries, and all of them resulted in complications. I know that the patient, and I mean, so many of these, I knew the surgeon, it wasn't a surgery, it wasn't a surgeon, it is the healing capacity of some patients. And this is usually genetically destined condition. And most of these patients, again, have either a history of diabetes themselves or have family history of diabetes. I can't even tell you over the last 40 years how often I discovered patients of diabetes that they didn't know about, discovered patients who have a family history of diabetes they didn't know about. Whenever I see frequent infections, I'm going to look into diabetes or poor healing, and that has helped me. And unfortunately, it's not common, but it is something to think about. These are extremely frustrating cases. You can imagine how frustrated the surgeon before me was doing the same thing and even covering the patient with antibiotics, but getting into trouble.
Another thing you mentioned as an aside, and I just want to say this for all the people, I think all of us that do a lot of revisions understand this, have experience, but for the people who are coming up through the system is you can never really judge what happened in someone else's surgery. If you're seeing some complication, if you're seeing a revision patient. So I think just to caution to those of you who are junior surgeons out there, you should not pass judgment. We're all going to have these things happen. Unfortunately, sometimes they happen. So unless you were there, you really don't know. It's just a word of caution for those younger surgeons out there.
Excellent point, Sam. The only surgeon who doesn't have a complication is the one who doesn't operate. Bahman, I enjoyed your presentation. I remember listening to you speaking about the suture, the quilting suture to straighten the cartilage years ago. And I always wondered, what happens when you use the 5.0 PDS? What happens when the suture dissolves? Wouldn't the cartilage rewarp? You're counting on the scar tissue, or why wouldn't you use a permanent suture?
Yeah, Tom, that's a great question. And the choice of non-absorbable versus absorbable cartilage came from a research that my residents did under my guidance many years ago. We demonstrated that if you change the shape of the cartilage for 3 weeks, that is all you need. The cartilage is going to stay in that shape. And we showed it experimentally. That's when I stopped using any non-absorbable sutures on the nose, except for tip suspension, because or tip rotation, I want something to hold the tissues back up permanently, not to let the aging gravity affect. So I don't use any non-absorbable sutures in the nose. And it came from that research. So all you need is 3 weeks, and this obviously PDS even lasts 6-8 weeks. I mean, 2 or 3, sometimes 3 months. So that is plenty of time to avoid that warping.
Excellent point, and I really like your analytical approach to that, and the fact that you're sharing that. Also, the permanent support sutures, it's okay to use permanent sutures. I mean, places where it's really important for strength, and I kind of adhere to that same philosophy.
Hey, Sam,
any other comments?
can I add?
Go ahead.
Yeah, can I add one point? Thanks, Bahman, for that. Absolutely, we always watch how your work is absolutely stunning and beautiful since I've been listening to you for years. Hyperbaric oxygen, just to give everyone who's listening, I've been using that on actually all patients that will actually pay for it, since it is an extra add-on cost. It's about $250, $100 to $175 a session for an hour. I've been using that for 16 years. Especially, I have a lot of patients that get an ischemic tip after I'm done with them, and I still use leeches all the time. And so hyperbaric oxygen for everything I've been using, from just swelling to basic healing to infection to ischemia, it is something that if you have a great source in your local town, and there's an excellent doctor, usually even a regular pulmonologist or a general medicine doctor usually runs them, and they're pretty good at it. Always introduce yourself, meet them, talk to them, and then send some of your patients and try it.
Do you do 7 dives before or after, I mean?
I'll try to do, if I'm really worried about their nose, I'll try to do 2 pre-op and 5 after.
Okay.
And they'll extend it to about 9. And the most these patients are going to take is going to take usually about an atmosphere and a half extra, maybe an atmosphere. Because, you know, we're living usually, at least where I'm at an atmosphere in LA. And the issue, one thing though, to tell everyone, when you have your splints in, when they're congested, a lot of these patients, one, if they have anxiety, you got to give them a little something to relax. 2, you station 2, you get plugged up. So if you're okay with that, you got to give them a little bit of a Sudafed or a Claritin D or something to get them ready before they undergo. Otherwise, and they got to go down slow. So the specialist who's there has to bring them down very, very slow and gentle. You know, otherwise they're going to block.
Excellent points. Interesting that you do that. Those are all revision patients or even primaries?
No, I do primaries. I mean, for example, I do primaries, faces. I just had a patient who came to me, and I'm sorry, I'll move on to this fast. She had a dog bite and to her right ala, and she lost it, but she didn't show up to me for how many days after? I can tell you about a week after. And so I go, oh my God, I don't know what I'm going to do. I ended up doing a complete full thickness skin graft and cartilage, a composite combined. And I thought at 7 days, she was on a horrible antibiotic. I thought that she wouldn't even do well. Got her straight to immediately hyperbaric, got her some Trentil, a little bit of that is of a frustration that I went through, and I've had to do that twice, but we all have to be very careful about infections and anything we put in the nose. Thank you.
Thank you, Paul. I mean, that's a really interesting case to share with us. I really appreciate it. And of course, thank you to the patient for allowing you to share that. So, you know, it's an interesting point because septal buttons, you know, for lack of a better term, can look really gross inside the noses, you know, if they've been there for a while. There's all sorts of stuff growing on there. I wonder if this is, I really wonder about whether just having that in there was part of the problem, because you really can't, you know, not that we sterilize noses. I know sometimes, I think some of you, maybe you, Paul, use Bactroban in the nose for a while beforehand and everything. But if you have this foreign body in there and all the, you know, stuff that's on that, maybe it's a good point. People should remove those a couple of weeks before surgery and plan on having them out for a while. Tom, did you want to make a comment?
It's not so much the button itself. Years ago, we did a study with Gore-Tex, and the patients with perforations had higher risk of infection, not the button. The perforation is a portal. It's the perforation that's the problem. Just
because perforations can get kind of nasty and have lots of crusting and so on?
It's an entry portal.
Mm-hmm. Yeah. Mm-hmm. You know, the interesting thing is we culture every patient before surgery. We've been doing that now for about 8 years, and I think we've had a few papers written up about it. And everyone gets cultured to see what they grow. And this patient didn't really have, you know, some normal flora when we cultured her, just basic culture, not a mycobacterium type of, for AFB type of culture. And everyone gets treated with Bactroban for 5 days before surgery. And interesting, it just wasn't a red flag at this point.
Mm-hmm. Any other comments from anybody? Now, do you find, go ahead, Yong-Ju, go ahead.
Yeah, thank you for sharing. I think it's invaluable indirect experience for us to know that. I think that the dorsal augmentation is the most complication-prone procedure in rhinoplasty. really respect the Paul's frankness to show this difficult complication. We do have many complications, whatever. We often just thought that those are implant-related complication is only for alloplastic implant, but I don't think so. Whatever material we use, we have a high risk of complication like he showed us. I think the costal cartilage, once it got infected, I think the best way is the early removal as early as possible. Yeah.
Paul, did you test this patient for diabetes or sugar or A1C to see if the patient is diabetic by any chance?
Her past medical history, especially even when she went into the hospital, I think she had a little bit of high blood pressure, but I didn't do a hemoglobin A1C, but she doesn't have a history of diabetes. And that's something, you're right, that we always look for, I mean, looking for anything that is a risk to get these patients infections. I mean, on that. By the way, I just want to make one statement from Dr. Jang. Since then, and it dovetails into another conversation, and I've been using his templates for dorsal augmentation, but I've switched 100% to these diced cartilage glue grafts, just tissue and diced cartilage that so many different doctors, especially in Turkey, have. I mean, there's so many different documentations and renditions of it, but I've been using that for the last, I think, year and a half, and we have about using it everywhere in the nose, probably about maybe 300 cases already. Oh. And so far, I've fallen in love with that. Haven't had any major issues yet, but of course, we'll follow up with that in the future.
Yeah, I agree. I've been using that now for a while and really find it really quite good. Brian, did you want to say something?
Yeah, a question for Paul, because you have a lot of experience with these things. Nanofat, microfat, fascia, and nanofat. I've played with it. It's done some amazing things, but I'm wondering if you have any comments on that for these patients where, well, let's say you go back a few steps and pull it out early and fill it with some sort of fat in order to restore or preserve or rehabilitate the soft tissue.
Yeah, I mean, when I was using the DCFs, I was using microfat or SNF or SNE, sharp needle intradermal fat, depending on what you want to do into the skin, especially when the skin's bad, especially nano fat injected into the skin through the entire nose. But since I stopped using DCFs, I'm not doing like, I'm not taking or you can take the perichondrium like Dean does, and which we'll do, we'll put some sharp needle fat. It's not intradermal, obviously, but it's into the perichondrium, and we will inject that. And then again, with any damaged skin, I use a lot of nano fat on the entire nose, and then of course I'll bring it on to the rest of the face for the rest, for the patient, for a little bit of benefit from there. And I feel that so far, nano fat or anything emulsified, when you get the multipotent stromal cells, I physically have seen wonderful transformations of horrible skin. Because Brian, you and I have talked about this. We'll do these patients that come in for the 9th or 10th rhino, just like the rest of these incredible doctors that are on this panel. And that skin's horrible. And you got to do anything you can to get that skin prepped so that it doesn't have, again, problems, during surgery. And so that's another incredible way to go and take care of the skin.
Yeah, that's an interesting thing that I know Dean's been talking about and is published. I'm going to take one question from the audience real quick. Then we'll move on to Tom. Someone asked, can you please discuss your preoperative and postoperative antibiotic protocol? Briefly, for those of you on the panel, how many of you use Bactroban routinely in patients, mupirocin, for a week or some sort of time beforehand? I know Paul does. Okay. I do it in healthcare. I do it in healthcare workers who are at risk for having MRSA and patients who documented MRSA, but I don't routinely.
I do the Cipro soaks for a week before also.
Tell me about that.
Again, Dean told me about this. Dean did my nose years ago. And of course, I was the first-hand, patient who actually did it. It's a 2x2. You take, if you have a 500 cc bottle of saline, keep it refrigerated, and you put 500 milligrams of Cipro, crush it, and then you refrigerate it, shake it. And, you know, he makes you do it 1,000 times a day, but of course, if you can get a patient to do it 3 times a day, it's good. And I'll continue that for about 10 days post-op. Take the tube I do, dip it in, and then slide it in your nose as far as you can with the end of a hard end of a Q-tip or something. I do that.
Okay.
I just started doing on really risky patients, especially depending on what they come up with those cultures. You know, he puts an angiocath in there and he leaves it in, as you know, does the irrigation.
Yeah, I don't know. You know, to each his own. I'm not going to speak too much about that. And I do typically now 3 days of postoperative staph coverage. That's about it. I'm not talking about revision. I'm talking about primary. So people at risk or other things are going to get something else. Tom and Yong-Ju and Brian, what do you guys do? I know Bahman, by the way, I want to thank Bahman. He had to go at 10 a.m. Pacific time, so he let me know ahead of time and just wanted to say thank you to him.
I'm going to cover it during my talk.
Okay, you're going to cover it. All right.
Regarding antibiotic, I prescribe about 5 or 6 days post, but I think the antibiotic has not that central role in preventing infection. I think the most important thing is that the host factor like a circulation and intraoperative stringent measure to be sterile as possible. So I'm not sure whether the antibiotic really work for preventing infection.
I think, you know, host factors are definitely underrated. I think that's such an important thing. And that's why we were asking about whether these patients had immunocompromised. Brian, what was your routine?
Primary, I do nothing pre-op. Post-op, staph coverage similar to what you're doing, Sam. Just a staph regular run of the mill. I don't do preoperative testing. Maybe I should. Secondaries, I'm all over the place.
Right. Okay, well, I think that's a good segue into Tom. It's a great pleasure to have Dr. Tom Wong, a good friend and colleague with us. Hope things are good up there in Portland for you, Tom, and he's going to share with us thoughts about complications with regards to infection.
Thank you very much, Sam. Thanks for hosting this, and thanks for the kind invitation to participate. This has been an excellent panel, and I think you can see a theme here, things that we've all encountered in our different practices across the country, across the world. And Sam didn't specify which kind of a complication to discuss, and one of the things that I've been encountering more with is infections, as others have talked about. So I'm going to share with you a little bit of my approach and do it. Sam asked us to present this in a case format, so that's what we'll start with. This is a nice young lady who had a little dorsal bump that she was unhappy with, and so this is done elsewhere, she underwent primary septal rhinoplasty with dorsal rasping about 10 years ago, and she was very happy afterwards. She let's see, here we go. How do we do this? How come it's not advancing? There she is. So these are pictures that the patient presented to me after her dorsal rasping procedure. She also had some miscellaneous septal procedures and so on. And then she developed a postoperative infection, a septal abscess that spread out throughout the rest of her nose and collapsed her left mid-nasal vault. So she went back to her surgeon, who then did the following: revision surgery with Medpor and Gore-Tex implants, and was stable for about 2 years after that. And then, of course, became reinfected and alloplast removed 8 years ago. And then she then underwent 6 further operations, revision procedures with autologous rib, ear cartilage grafts, autologous, of course. And they all became infected and extruded, not just through the nostril, but throughout the skin. And so her nasal skin became pocked and scarred, and she lost her native structure. The most recent surgery was 1 year ago to presentation with irradiated rib cartilage. She had a really over-rotated tip, which I'll show you shortly, to try to push that down, but that extruded through the left nostril and above the left nostril with severe constriction of the nostrils, further scarring and notching. She was quiet for about a year, and then she found me and then presented with scarred and contracted nose, severe airway obstruction. This is her after her rasping, and this is the way she presented to me in the office 1 year after her 10th procedure. You can see her nose is completely decimated. But as I've said many times before, when we talk about rhinoplasty surgery, certainly we're talking about refining the nose and improving the proportions of the nose to the rest of the face. But ultimately, the rhinoplasty operation is done to increase the beauty of the eyes and focus attention or redirect attention to the eyes. You can tell by her eyes, she has pretty eyes, but they're very sad eyes because of her nose. Base view, you can see the stenotic nostril. She can't breathe. This is where the cartilage came through. It's got a notched scar. This is where the original collapse occurred after her initial infection. That had been the effort of her other surgeons to try to correct. And she basically has a tight stenotic envelope. And so going back, it became clear that she had a history of MRSA infection on her thigh that required antibiotics a number of years ago. She's otherwise perfectly healthy, active. She has bony cartilaginous dorsal deviation. Her cartilages were essentially absent. Flaccid upper lateral cartilages, lower lateral cartilages, significant sidewall flail on inspiration, stenotic nostrils with notching. Nasal tip skin is just thick and scarred and a blob. The tip was amorphous, over-rotated, under-projected, basically unsupported and asymmetric. She has no caudal septum. She does have septal deviation after all this, and a 1.4 centimeter anterior septal perforation. And of course, the patient wants her old nose back, and she was in tears during the consultation. So here was the proposed revision procedure. Knowing everything up to now, I was hesitant to embark on this revision, but we discussed the need to restore dorsal caudal support since she didn't have any. Debulk the fullness and the miscellaneous grafts that are still lurking in here that hasn't extruded yet. She needs the dorsal rib reconstruction, diced cartilage to fill this indentation with the fibrin glue, and ear cartilage butterfly graft to support her internal nasal valves, articulated alar rim strut grafts, composite graft, left nostril to correct the stenotic nostril here, try to open it up, get it to be functional. A magnet septal button, I found that to be much better than the traditional septal buttons, and I've become a big fan of that. And of course, the biggest difference is MRSA prophylaxis, of which she had none in all of her 10 prior procedures. And so schematically, we went through an external approach through her previous stair-step external incision, removed miscellaneous grafts and implants that were lurking and buried within the tight skin envelope. And then reconstructed the dorsal caudal support. The way we like to do this is bilateral extended spreader grafts anchored to the columellar strut, secured to nasal spine to decrease tip rotation to try to lengthen the nose. And I have a short video showing how I do this. This is not this particular patient, but this just shows our general procedure. We mark out the dimensions of the dorsal and caudal aspects. And then this is with cartilage spine, so you can see the notch there in the spine. I put a stitch through that 5-0 PDS, anchor it to a stout piece of autologous cartilage that is secured and wedged in there, and then I secure that construct, of course, to the bilateral extended spreader grafts, and then to the native remnant dorsal cartilage. There's no caudal septum present in these cases. And this has been very effective, and we discussed this and presented it in an article about 5 years ago. I'll show the citation towards the end of the discussion. And this is secured both to the extended spreader grafts, to the native septal cartilage, and then we anchor the medial crura to the strut, and then we do a posterior transnomal dome binding suture. Again, this is a different patient because the current patient case presentation did not have these nice, healthy lower lateral cartilages to work with. And so this is how we secure everything. Once we were able to get the nasal length to the appropriate position, ear cartilage butterfly graft to support the nasal sidewalls and internal nasal valves, onlay dorsal autologous rib graft, dimensions noted there with perichondrial underlayer for fixation and sutured to the upper lateral cartilages, our bilateral articulated alar rim strut grafts to provide support and opening of the nostrils, and a cap graft to increase tip projection, ear composite graft to try to open up the left stenotic nostril here, which is collapsed and pinched and retracted. And then finally, some diced cartilage in a fibrin glue construct to try to fill in the lateral depression. There was significant tension on closure with the skin of her nose here, and that was quite concerning. I did not dare to debulk the fullness for potential loss of vascularity, because this is a very, very scarred area. This is her on the table right at closure, and you can notice how the blanching here of the columellar skin extending up to the tip. It's really white, and I was worried. The skin down below is fine. Here's the composite graft trying to open up the nostril. These are all scars from previous cartilage extrusions. It's hard to get the perfect outcome like this. And of course, part of the preparation with embarking on the 11th procedure, the revision on patients with these types of circumstances, is to let them know that they will not have a perfect outcome, so as to make sure we don't generate unrealistic expectations. This is her at presentation, and this is her a year and a half after surgery, after this one procedure. And you can see we were able to lengthen the nose appropriately, increase the tip projection, and create better definition. We'll show you some more pictures. You can see the oblique views, the collapse, the foreshortened nose, and overall, we were able to reestablish better contour with this combination of things. These are all 1.5 years post-op. Front view, again, when I see this picture, I see, of course, the nasal deformity, but really catches my eyes, the fact her sad eyes that she has. And here she is a year and a half afterwards, same eye makeup, but the eyes just look different to me. And the nose looks better, of course, from all those. Not perfect by any stretch, as you can see, very stenotic nostril with notched and scarring. And this is the composite graft, which fortunately took, but this area is such a mess. The tension, you can see the increase in tip projection. The tension did not cause, fortunately, did not cause any skin necrosis. We didn't do hyperbaric, although that would have been an option had it became more of a concern. And then straightened the nose, filled in this area, far from perfect. You can see the extrusion scars, and I don't know of a good way to deal with that. And the front view and the downward oblique view, you can see the nostril shape and symmetry is better, and we're able to get better tip projection. This area is filled out compared to that, but this left side or the right side is still a little asymmetrical, unfortunately. And so in her particular case, we know that postoperative infection risk is generally low in published literature, less than 5%. And in fact, the current best practices recommendation is to not use postoperative antibiotics, which is fine. The risk may be increased, of course, in patients with prior history of MRSA infection. We've written about that. And the consequences of these postoperative infections can range from mild to devastating. And so what we do now is the routine. We used to routinely preoperatively perform nasal culture to see if they're colonized. I've discontinued that because of cost factors and false negatives, and the fact you may not get anything and the patients may still have infection. The current protocol is pre and postoperative intranasal mupirocin ointment application, and I have them trim their nose hairs. I tell them to give their nose hairs a crew cut for a week before surgery for high-risk patients. All healthcare providers, a significant percentage of my clientele are physicians and healthcare providers. Any patient with a personal history of MRSA infection, so she would have fallen into that category, or if they've been in close contact, had a family member that they were taking care of with prior MRSA. And then postoperative antibiotic regimen for coverage, for MRSA coverage. And so these are the things that we do to try to minimize or mitigate these types of issues. The technical refinements and outcomes of the modified anterior septal transplant is here. We wrote about that back in JAMA in 2015. Here we actually wrote about almost exactly 10 years ago on MRSA in septal rhinoplasty, and Paul and Babek had a more recent excellent article on prophylaxis in rhinoplasty. Incidentally, a number of the faculty has been invited to the Portland Rhinoplasty course scheduled to take place this July, but unfortunately we had to cancel that due to COVID. So we're optimistically rescheduling it for next year. Please make a note of that in your calendar. And thank you very much for your kind attention. And thank you, Sam, for hosting.
Thank you, Tom, for that really great presentation. Very difficult case, and also just, yeah, that's a wonderful course for anyone who can attend. I highly recommend going to see Tom's course and participate, and see Portland in July, August. What factors in that patient do you think, I mean, without passing judgment on any of the prior surgeries, what factors do you think led to the problems? I mean, the infection, obviously, but was it simply a matter of not doing sort of the same infection protocol that you did, or was there other things, the use of irradiated rib, or that's one thing that caught my eye, other things like that?
I've actually used irradiated rib in the context of active infections, and it's done well. I think one of the big take-homes here is recognition of the potential for MRSA colonization intranasally, and then proactively trying to decrease the bacterial colony count. We have the patients clip their nose hairs, as I said, apply the mupirocin ointment for a week before surgery and for a month after surgery to try to maintain the bacterial count to a lower level. It may be MRSA, it may be another organism. I don't think the specific organism matters. I think what's key is trying to keep the intranasal environs as clear of colonization as possible. She, of course, has a septal perforation. It was clean edges, but that would be another potential portal for infection.
You mentioned the magnetic septal button. Do you think it's cleaner, or is it just you like them just because they're functionally easier to get in and out?
Both. They're easier to place. They're much sleeker. They're tailored. They're customized. They don't shake around, because the old button had a little center hub, and if you have a perforation that's bigger, then the hub can rotate in the perforation. The magnetic button has a larger hub, so it just actually fixates, and it's more stable, and it has a lower profile. So it is cleaner. It's much more better tolerated, more comfortable, a little more expensive, but I think it's worthwhile. You guys have any experience with that? Not that this is the topic of this discussion.
No.
Yeah.
I don't really do that with buttons much. I send those out. I send them up to Portland. So
Thanks.
So, we had a question. I'm just kidding. We had a question from the audience. What type of composite graft was used?
It's an auricular composite graft. For the stenotic nostril, we want a curvature with the skin on the concave surface and the cartilage on the convex surface. And so it's taken from the concho bowl, straight from the concho bowl, a strip that's about 1 centimeter in length and about half a centimeter, 3/4 centimeters in width, and then this closes primarily.
One technical question I have for you about that, and composite grafts have a relatively high failure rate in the literature, at least in skin cancer reconstruction and such, up to 30 to 50%. But my question for you is, how do you like to secure those in the nose?
There are a couple of aspects. You're absolutely correct. Composite grafts can be touchy. One consideration is the size. The smaller, I mean, obviously, the less the amount of biologic load, the greater the take potential. And so limiting it to no more than 1 centimeter or 1.5 centimeters at most is really important. I always pie crust the graft, that is stabbing it through the cartilage and the skin, so there's no possibility of seroma development. And then I fixate with through and through sutures, so it's a tight coaptation, so there minimizes the risk of shear of inosculated vessels, and those tends to be successful.
Excellent points. Next question, did you fix the spreader graft to the nasal bone in your reconstruction? This is not really related to the complication, but someone asked about that.
No, I have, and I agree with Jang. It is hard to do reliably, so it's difficult. So I did not in this particular case, but I really enjoyed Brian's presentation about that.
Any other comments from anybody? Okay, well, I think last but not least, we have Dr. Jang joining us from Seoul. And I hope you're doing well out there. It's really good to see you, and thank you very much for joining this panel.
Okay. Okay. Can you see this?
I see your folder, but I don't see the presentation yet.
Okay. Um, yeah, let me try this again. How about this? Can you?
No, I think it's just sharing that folder window. Maybe stop sharing and then try again, clicking on the
Folder?
window of the PowerPoint.
Okay. Let me try it again. Okay. Working?
No, I still see the just the folder. Try stop sharing.
Yeah,
Maybe Sachi can do it. Sachi, can you stop sharing for a minute? There we go. Okay, Yong-Ju, try now to open up the.
Can you see
There you go.
this?
Now it's working. Now it's working.
Okay. Good. Good to go. Can I start now?
Yes, looks good.
Okay. Yeah, thank you for invitation, Dr. Most. I will talk about short nose deformity today. I'm from Assam Medical Center, located in Seoul. And the short nose, this is typical patient coming to you with short nose. This is one of the most common complication of a surgical rhinoplasty. This is, and also one of the most difficult complication to deal with. So in our part of the region, the most common region is the silicone rhinoplasty done before. In order to correct this short nose, we should have some armamentarium in our hand. The most important thing is the septal extension graft to elongate the center compartment. And then we do need to do some of the techniques like augmentation and thick grafting. I think the fundamental, the central, the most important the technique for correction of the short nose is the elongating the central compartment with extended spreader graft combined with the caudal septal extension graft. So when you treat this kind of patient, you have to put your every attention to elongate the central compartment, not project that much. So this is the typical case who benefit from the placement of the extended spreader graft combined with caudal septal extension graft. As you can see here, I was able to derotate the nose as seen here. But there are some difficult situation when the patient has totally missing septal cartilage and the mucosa is badly damaged and there is big perforation. We cannot elevate the septal mucosa flap. We need to do some different way of elongating and stabilizing the central compartment. So we need to implant L-shaped implant designed like this. So today I brought two cases who had a rhinoplasty done using this way. And those augmentation is also very important aspect of the short nose correction. I mostly use coastal cartilage. Nowadays, I use mostly glutatized cartilage. So this is the cartilage mold. I'm using this from about 2 years ago. So I'm dicing the coastal cartilage with using Domaton blade and 10 blade. And actually now I'm developing the dicer, which can make my life much more easier. So I'm dicing the cartilage with Domaton blade, and I open this mold. And this is homologous fascia. I like to use this material because I don't need to harvest additional fascia, temporalis fascia. This has a very good performance. I've been using this more than 15 years. So I place it at the bottom. It will be in contact with the skin. The purpose is that I want to decrease the chance of the irregularity created by the diced cartilage. And then I paint the glue, and then I place a little bit of diced cartilage, and then I paint more fibrin glue. And as you can see here, there is some water around the diced cartilage. So this water and glue create a false volume, which increase the unpredictability on the final shape of the nasal dorsal height. So nasal dorsum. So as a final step, I squeeze it out with this a compressor. But there's a hole here, so you can easily remove the excess glue and fluid around the diced cartilage. Then you can decrease the false volume created by the glue and the water. So this is the final implant. As you can see here, it is covered with fascia to decrease the chance of gravity showing an irregularity. And then it has concave surface, which will cooperate very well with the native nasal dorsum. So it has many different lengths and thickness, so you can use it for the segment augmentation. Let me introduce this patient. She underwent about 5 times rhinoplasty. She also experienced infection. So she was very, very despondent and hopeless. So as you can see here, there's perforation here, and then there's loss of tissue plane, severe deviation is also there. So I harvested her 6th rib, and I created a one L strut graft, and then I made a dorsal implant like this. So this is intraoperative video showing how I do this patient. As you can see here, there are so many scars caused by previous rhinoplasty. And I'm removing the cartilage inserted by previous surgeon. And as you can see, she has no bleeding. She has really compromised the circulation. And it was very difficult to find the good tissue plane there. And I'm separating the medial crus, and I'm removing a little bit of cartilage which was placed in the previous surgery. And this looks like a columnar strut. And it was very, very, as you can see here, there is a mucosal defect. And I tried to elevate the septal mucosal flap, but I found that it was very difficult. So I opened the rib, and I harvested 6th rib, which has angulation like this one. So, and I'm exposing the anterior spine, and I drilled the anterior spine to pass the needle and suture material for fixation of my L graft. And then I also, I repaired the mucosal defect here. And then there occurred a mucosal defect on the upper lateral cartilage right here. So I covered here with perichondrium. And then I just closed the septal mucosal flap, which was partly dissected. And then I implanted L-shaped implant made of 6th rib. It looks yellowish because I put it in the betadine. And I try my every effort to stably firmly fixate, secure this caudal part to the nasal spine. And then I'm further stabilizing this L strut with some soft tissue around the upper cartilage. So I was able to create a central supporting framework. And then it was covered with perichondrium. This is costal perichondrium. And I also harvested removable fascia with fat. And this was further covered with fascia with fat taken from the chest. And Hodojum was augmented with the diced cartilage with glue designed by using my mold. So here she is. It's about 1.5 year post-result. As you can see here, her dorsal line looks much better. And it's not perfect, but the scar became less obvious, and profile line and 3/4 view shows acceptable results. So now she is back to her normal social life. This is another case, second case, who also visited me for desiring the reconstruction of his short nose. This patient had about 3 rhinoplasty, also had the silicone rhinoplasty, got infected and removed elsewhere and referred to me. And as you can see here, his septum is badly deviated. Mucosa is very thin. So in this case, I harvested his 7th rib, and I designed the integrated dorsal implant plus columella strut. So I'm dissecting his skin. As you can see, not that much bleeding, severe fibrosis, scar tissue everywhere. It's very difficult to dissection. And I'm trying to make a pocket between the both medial crus. And then I tried dissection of the septal mucoperichondrium because there was septal deviation, severe caudal septal deviation, but I found it was very, very difficult. During the dissection procedure, I made some injury on the septal mucoperichondrium, so I didn't process the dissection that much. Instead, I removed some of the cartilage through the nasal cavity, as you can see here, because it was almost impossible to dissect, completely elevate the mucoperichondrium. But I had to correct his caudal septal deviation, so I partially dissected the mucosa, and then I'm correcting his deviated caudal septum. That's it. And then I designed the A-shape implant with a 7th rib. And this is integrated implant with dorsal implant plus columella part. And this was inserted here, and I'm fixating it with the anterior spine here. And I'm securing this with the lateral crus here. And I added one more T-graft for further elongation of the tip. So this is about 14 months post-result. As you can see here, I could reconstruct his dorsal line, broad-tip line like this. And scar is improved a little bit, and dorsum was augmented, and T was derotated. Dorsum was also augmented with diced cartilage, molded with diced cartilage with glue, covered with fascia, molded using my cartilage mold. So this is my book, this is my video. I recently opened my YouTube channel where you can see many instructive videos. Yeah, thank you for your attention.
Thank you very much, Dr. Jang. Very interesting cases, and the short nose is really one of the big challenges for us. What do you think are the factors leading to? You said most commonly it's use of the silicone implants, and so
Yeah.
presumably these were infected, removed, and then the patient shrank because they weren't repaired primarily.
Yeah.
So
But the thing is, even without infection, in some patient, they form exuberant capsule around the silicone, and then this the capsule causes contraction of the whole nose. So this short nose deformity can develop even without infection. So this is a common complication.
and so in these patients that have the short nose and the skin envelope, as Tom mentioned, you know, because he had a lot of tension on his closure. Actually, I'm going to ask you to stop sharing screen if you can for a minute. Do you have any tips for how to try to improve that? For example, Rick Davis and others have now started asking patients to massage the area to try to loosen it up a little bit for a couple of months ahead of time. I don't know that it makes any difference. Do you have any tips? Do you use hyperbaric oxygen in these patients if you're concerned about blood supply or any other tips like that?
For the short nose patient, I routinely put them on the hyperbaric oxygen chamber treatment. If I found that their circulation is really, really bad, then I routinely do post-operative hyperbaric oxygen chamber. And regarding the skin massage, I saw some dramatic result in number of patients. While they're waiting for the surgery, I asked them to pull down the nose with fingers, and then a number of patients showed their short nose looks a little better, and their skin become a little more softer. Yeah.
Very interesting. Very interesting, actually. Tom, you were nodding your head. Do you ever use HBO?
Rarely, but I do find the massage helps because the skin is an elastic organ, and you can train it, and that is helpful. We do have patients do that.
Yeah. Brian?
I'm always a little skeptical about massaging. I think it matters, but I'm wondering if there's some sort of optimized way of doing it. That I'm curious if Tom or Yong-Ju or Sam have any sort of kind of a process on how you do it. I mean, how can you optimize it? I'm wondering. I don't have any advice on these short noses. Yong-Ju was a great, incredible presentation.
You know, I ask patients, there's no real rule, but I ask them to do that downward massage and kind of stretch the skin for a few months ahead of time, a couple of times a day. I don't want them to obsess about it. I also think, though, that it's, you know, making your patients an active participant in the care always helps. Knowing that you're doing everything you can to optimize things is helpful. I'm really interested to hear that Yong-Ju's actually seen patients with slightly, perceptibly longer noses.
Yeah.
Very interesting.
Just not all, but some. Yeah.
Yeah.
Some patients.
One thing, so somebody in the audience asked, what is the fascia alternative? So that's homologous fascia. Someone's asking where you get that fascia. That's something you purchase. It's homologous fascia that you get frozen.
Oh yeah, I got from the tissue bank from US.
Yeah.
And but to make the implant, I can use a perichondrium to cover the outer surface of the gluteus cartilage.
Yeah.
Perichondrium, or you can use rectus fascia, or you can use temporalis fascia. But I don't enjoy harvesting rectus fascia because I had experienced a number of delayed bleeding after the fascia harvest.
That's also very painful. I think the rectus fascia is very painful. Your device is very interesting. I have not used it. I may try it, but you bring up a couple of good points. One is with diced cartilage, really important for me. I make sure it's all less than 1 millimeter in width, all the cubes. It has to be. I've seen presentations where they're big chunks, and I know that's going to show. I don't think fascia over it's going to help if they're big chunks. I think most importantly, cutting it very finely. And secondly, your comment about false volume is exactly on point because I've also seen presentations where people show this cartilage floating in like, looks like in jello, and you know that stuff's going to disappear. It's very important to desiccate it before you put the glue on. So I squeeze it, put sponges on both sides of my blades and make sure it's dry as a bone, then put it in. And then I just use a 3cc syringe cut in half, and I put a Telfon and squeeze it pretty hard. And I'm looking through the plastic to make sure that those cartilage pieces have no extra tissue glue between them. So it's the same concept. I think your device probably makes it much more simple. So I applaud you for that. That's really nice. Any other comments from anybody about the presentations on short noses? I have one more question, but my question is this, and I pose this to Dean and others when I see these large reconstructions where we're building huge L struts with big pieces of rib cartilage. Do you find ever that these patients either palpate those in their nose or that they complain of nasal obstruction from that massive reconstruction? Often, of course, it may not be an issue because they were so bad beforehand that they're just happy to have a nose again. But what do you do to mitigate that problem?
Not specifically, not about this big L graft, but if you the most common way of reconstruction for me is placement of the two extended spread graft sandwiching one quadriceps extension graft. Sometimes if it is too thick at the colon line, this will block the airway of the nose. So I try to trim it down very carefully. Yeah. And one other thing is that I have a number of patients who complain that my nose is too rigid. Yeah. So yeah, they look very good, but some patients want to remove it because they cannot tolerate the rigidity. So I think it's very important to, during pre-op consultation, you have to discuss about all the possible consequences and the pros and cons. And so then if that the patient has some understanding beforehand, they can tolerate. But I think it's very important to have a good discussion, the pros and cons of the big,
excellent point. Yeah, I think that, these big reconstructions are invariably going to be a bit stiffer, and having that discussion with them is very important so they understand that. A couple more questions and then we're going to wrap it up because we've run over a little bit. One is, does anybody on the panel ever use phototherapy or laser therapy to improve the skin postoperatively?
Not in rhinoplasty. I use lasers routinely for scars, but not on the skin for rhinoplasty.
Yeah, same here.
I have a few patients who developed telangiectasia at the nasal dojo who underwent dosal augmentation. Sometimes I send them to a dermatologist for skincare.
Yeah, some IPL or something.
Yeah. I work with Stuart Nelson, who's one of the top dogs in cutaneous laser surgery, and we have a very good relationship. The one thing I would say, though, on redness and telangiectasia that people have to be aware of on the revision patient, not the primary, is that sometimes that's the dominant vascular supply to the skin. So if you knock it out, it just grows back because there's not a dermal subdermal plexus that's particularly viable. And you kind of end up chasing your tail. On the revision, the multiple revision patient, you knock them out and they come back. It's because there's nothing else. Primary, it's different because you still have that dermal layer. It just, if you're doing for redness, go with a vascular dermatologist that does vascular lesions. For scar, all of the fractional techniques are fairly equivalent, and they work really, really nice. But again, I'm lucky to have such an incredible colleague.
And you're pretty accomplished in laser technology yourself, Brian. So
not me, it's him.
Okay, well, we've run over by about almost 20 minutes. I want to thank all of you. I also want to thank Bahman and Paul, who both had to run, especially Yong-Ju for coming all the way from Seoul. I hope everyone stays safe and healthy, and I look forward very much to seeing you again in person, perhaps in Portland next year, or maybe in Seoul, who knows, somewhere. Take care.
Let's count on it. Thank you, Sam.